Today we're joined by Stephanie Taddeo from COPC. Stephanie is a social work care coordinator for COPC. Welcome to the Service Coordinator Podcast, Stephanie. How many podcasts have you been on so far?
Oh, thank you. I'm glad to be here. I've been on the radio. Remember the radio? I've done that a few times, but this might be my first podcast.
Wow, the radio is live, so that's intense. So yeah, if we say something wrong or bad words or whatever, we can just cut them out. So don't worry.
Good, because I do that a lot. So that's
okay. Maybe we can bleep it out. All right. Well, welcome to the show. As you know, we talk to service coordinators all over the country about their work with seniors. And Matt said you would be a great person to bring on today talk about end-of-life care, about hospice care with seniors. My family just went through this whole scenario all summer long, so I'm very familiar with the hospice experience, which was great. But throughout the years here at National Church Residences, 15 years or so, it's always been the hot topic that's off to the side. Like, how do we get hospice into our buildings? Because it's such a tough discussion for service coordinators to have. Because it's typically just a service coordinator and that resident. Sometimes there's not family involved to help that resident make those tough decisions. Maybe the physician's not there to really have that long conversation with them. And so it does come back to the service coordinator a lot of times. So Matt and I thought we would bring you on to kind of give some tips and ideas and maybe go a little bit more in depth about how service coordinators might be able to bring up these conversations with residents that could really use the care. So welcome to the show, number one. So Matt, do you want to start off with the first question? What are you thinking of asking?
Well, thank you for setting that up, because you basically summarized exactly what we'd love Stephanie to give us her insight on. But before we get into having that conversation, I still think that there's a lot of confusion regarding what is palliative care versus what is hospice, and how they work together, and how both types of care might really empower an older adult who frankly lives in one of our affordable housing apartment buildings to truly, live their entire life there, because so many of our residents will look you in the eye and go, I want out of here feet first. I don't want to go anywhere else. This is where I want to be for my entire life. So If you could talk for a few minutes about palliative care versus hospice and how either of those could really help support that wish of aging in place, that'd be a great start.
Absolutely. So palliative care is like a big umbrella. So, Matt, you and I have been doing this long enough that we can remember when that wasn't even a specialty that physicians could choose, or there wasn't a board certification in it. Right. Now, physicians can get special training in palliative care, and the broadest way to describe what is palliative care is the goal of palliative care is to alleviate or prevent suffering. So who could be against that, right? That's a no-brainer. We're all in favor of reducing or eliminating suffering. And so there are physicians that specialize in it. There are whole teams that specialize in it. And that's my role at Central Ohio Primary Care now, as I work on a home-based palliative care team, a team that has palliative care physicians and nurse practitioners. But it's not just about the medical, because when we talk about suffering, it's more, we're more than empty shells, right? We're more than walking carcasses. So we have me, social work, and my social work partners. We have nurses. It's looking at the whole person and the whole picture, not just about their body. So anyone who has serious illness or has unmanaged symptoms is appropriate for palliative care. Hospice, on the other hand, is a program. So palliative medicine is like cardiology or nephrology, when we have these different kinds of specialty physicians. But hospice is a government program. Medicare defines it. Even if you have private insurance, Medicare still defines it. And if a patient has less than 6 months to live, and we know that prognoses are an art and not a science, and sometimes they're not right, but if two physicians agree, they have a prognosis of 6 months or less, and very importantly, that they want what hospice has got to offer, they believe in the philosophy of hospice, then they can elect that benefit, and that benefit comes with a lot of stuff. It comes with a team, it comes with someone on call 24/7, equipment, medicine. So that's a program. Hospice is palliative care, but palliative care isn't necessarily hospice. Palliative care is broader, and it encompasses, that relief of symptoms. So like on my team right now, we have patients who have a very serious illness, like they've had COPD for years, they have heart failure for years, and they're not getting better. The chance of getting well is not an option, but my team can help them feel better. We have patients who have cancer who want to keep doing chemo. And the oncologist has said, yes, let's keep doing chemo. There's more chemo, there's more radiation. Maybe they want surgery, but they still have those symptoms of cancer, whether it's pain, nausea and vomiting, issues with their skin, anxiety, depression. Those symptoms can still be aggressively managed while someone is getting aggressive curative treatment. So that's kind of the difference between palliative and hospice. Both believe in treating the whole person, but hospice is for patients and families who say, I don't want to go back to the hospital no matter what. And and a physician has told me I have 6 months or less prognosis, educated guess. And palliative care can be way broader than that. Some palliative patients also don't want to go back to the hospital. And that's what I think for your service coordinators. I've never been a service coordinator, but I can imagine that a lot of the residents say, I don't want to go to the hospital. Hospitals are not pleasant places. I was just in one recently with my mom, and it's terrible. There's nothing, I'm glad they exist. People need to be there. But is that what you find with your service coordinators, that they hear that a lot, I would assume?
Yes, and I think you've alluded to this, Stephanie, in that so much of the time when you have an older adult who's a resident and maybe they have some chronic conditions, usually, not always, but the more that disease process goes on, every time they go to the hospital, when they're discharged, they actually feel worse than when they went in. So they start associating feeling really bad with going to the hospital. And frankly, in many cases, that association is quite accurate. So even though that's a great point, we have residents who don't want to go to the hospital. They're not medically eligible for hospice, yet they don't want to go to the hospital. And it's almost always about symptom management. Like you said, the chronic obstructive pulmonary disease where they have an exacerbation, or congestive heart failure where they're moving into heart failure. And I'm assuming physiologically, those are some of the things that a palliative program would address, correct?
For sure. So if the patient and family's goal is to avoid hospitalization, then our job as a palliative care team is to say, let us help you make that happen. Like, what medical things can we do? Which might be medicine or equipment or education about, oh, hey, when your weight goes up this many pounds, you call us. But it's also what services are they eligible for? How can we wrap them up, give them and their caregivers the support they need to meet that goal, if it is to stay out of the hospital. And for most people it is, because like you said, they come home feeling not better, oftentimes worse. But we also see with older adults, if they have even a little cognitive impairment, like they might get along just fine when they're in their house with their people. But a hospitalization can really move that mild cognitive impairment into a delirium where they just don't feel like themselves.
Right.
Their cognition, it takes them a long time to get back to baseline once they get home. So I think the number one thing for your care coordinators to understand is, or service coordinators say, is that there are options. So many of these patients have not been told, you know what, it's your choice. You don't have to go back to the emergency room. You don't have to go back to the hospital, but you need to have things in place to make that goal a reality. Physicians physicians have different levels of comfort about having those discussions or looking ahead to, oh gosh, I can really see this patient going to the hospital again in a month, 3 months, 6 months. Let's talk to them about, do they want to do that? And if not, what do they need to be able to make that happen?
I mean, your segue is beautiful. I think you're setting yourself up, Stephanie, which brings really to the next point. Once we understand the difference between palliative care and hospice and what the goals of those are, programs or approaches or type of care versus program, can you help our service coordinators with what I'm going to call some tools, some guidance based upon your years of experience? Yes, we know you started in end-of-life care when you were 12. That's what we're going to tell people. But openers, how do you begin that conversation? Because I really think so much of it is just beginning the conversation. And once it's out there, it kind of, and I could be wrong, but I get the impression it kind of naturally flows. But how do you as that psychosocial expert raise that question?
Number one is listening. So I spend a lot of time telling myself to be quiet.
That's good for anyone to do.
But when the older adult is talking about their emergency room experience or saying, they'll take me out of here feet first, or we have older adults who are really clear about what they want and don't want. So listening to that and then asking them to clarify it. So are you saying, under what circumstances would you want to go back to the emergency room or hospital? And then it's really about the service coordinator knowing the resources. Is there a palliative program? What's palliative like in your neck of the woods? So it's still an emerging field and programs vary wildly. What I can tell you, in whatever market your service coordinators are in, there's not enough. Like there's no competition among palliative care. Everyone's like, yay, come on, everybody do it.
So is this, I'm going to jump in right there.
Please.
So is the palliative care program, is this something a doctor's got to decide, hey, I want to bring this into my practice, or this is what I want to be trained upon, and then I'll bring staff in underneath me? I mean, so it's kind of an ordeal for a physician to say, yes, let's go ahead and move forward with this. Is that why there's not many out there, or it's just more still, it's just an emerging type of field within that?
It's an emerging field. Physicians themselves, depends on what system they're affiliated with. There aren't many standalone docs anymore. People don't have their own practices, not zero, but not many. So the physician should be familiar with the options in their system. If they're affiliated with a hospital system, or like with COPC, we're physician owned. Everyone's doing it a little different. So that physician needs to know what options there are. Another thing that's emerging, and I am not an expert on this because it's a really new thing, but insurance companies, Medicare Advantage companies are now hiring palliative care providers to do visits to the patients they insure. And the goal is exactly what we're talking about. Somebody who's really comfortable having this conversation, go talk to the patient and family and say, hey, tell me about your goals. Like, is this okay with you? What's your line in the sand? Sometimes we say, like, patients will say, well, I want everything done unless I can't work in my garden, or unless I can't spend quality time with the people I love, or I can't watch my favorite show. Everybody has different lines in the sand.
Right.
But it does take some comfort in having that conversation. I wouldn't expect the service coordinator to be able to take a resident from A to Z. What I think would be great is if the service coordinator hears the resident, because they know them, they see them, they have conversations with them, and they see a decline in the patient, or they know about calling 911 or hospitalizations, or zillions of specialty appointments, and the service coordinator can say to the resident, how's it going? Like, do you feel like people are asking you what you want? And if they're not, what do you want? Is this okay? Do you want to keep going back and forth to the hospital? Or do you want to talk to someone who can walk you through the options to reduce or avoid that from happening? Or patients who have a lot of discomfort, they have a lot of suffering. Hey, are you interested in finding out what resources there are to address the complaint, whatever the service coordinator is hearing about? Because opening that door, so many people are not asked. They go to specialists, and specialists are trained to treat the thing, right, that they specialize in. And a palliative care provider looks at, oh my gosh, you see all these different specialists, and here you are in the center. Is this okay with you, or are you just following orders? Are you being directed, or are you directing the care that you're receiving? And anything a service coordinator can do to say, hey, this is your life. What do you want? How can I help you get the services you need so that you can live it the way you want, within the bounds of reality? We're not magic, but I think that would be a huge gift that a service coordinator could give a resident. I also think it's really important for your service coordinators to understand that, of course, our history, our background, influences how we feel and think about such things. So another reason I tell myself to be quiet is to be able to empathize and try to walk in that resident's shoes. So they might have perceptions of systems that I don't have. They might have values that I don't have, and that's okay. In the team I'm on now, some of our patients have metastatic cancer that is not going to be cured, and they want to go out swinging. They want to go to the hospital over and over again. That's okay. They want to keep doing the chemo that makes them sick. And we have to suspend our values and say, we're in it with you. Like, okay, we hear you, and we're going to continue to try to help make you as comfortable as possible, even with that decision that you've made to continue the aggressive curative treatment. But it's hard to keep all the things in mind, but the culture that we grow up in, the religion that we're raised in or that we practice now, our immigration or refugee status. Those are all things. The system is not equally kind to all people. And so the service coordinator should understand that it might not be what you think the person should do, but be open-minded to, standing in your shoes, I see that maybe hospice is a bad word.
Mhm.
Yeah, totally. Like I said, I dealt with this, over the last 6 months to a year with my parents, and you bring up the word hospice with my dad or my mom, it was like, hey, totally giving up. We're not taking any more pills. And when it came down to it was, it's like, hey, do I want to keep on going in and out of the hospital nonstop? And they're getting emails from one doctor saying do this and another doctor probably 5 different doctors, and it just finally came down to like, hey, my mom said, I don't want to take 20 pills every day. That was all, that was the conversation. Right. But
that was her line in the sand.
Hey, that was her line in the sand. Yeah. And we really didn't know what that was. It was just kind of like we were just waiting. So I think that's great advice to listen and say, hey, what exactly do you want to just keep going till the end or what? Because there are other things we can do. So that's the advice. So
no. And I reiterate that too. I think so much of the time, no one really asks the patient what they want. Everyone makes the assumption, well, this is standard plan of care, so this is what we're going to do. And no one says, this is what we're thinking about doing. How do you feel about that? And is this really going to achieve what you're hoping to accomplish? So I think that's beautiful. And so much of the time, our service coordinators, and you implied this, Stephanie, they have a unique relationship with these residents because they see them day in and day out, and they can have these conversations ongoing about what the patient, or what the resident might really want. And I suspect, and confirm or deny this, that sometimes what people want, it actually changes throughout the disease process.
Sure. It could take one event to be like, oh no, I thought I wanted this, but no, that was really unpleasant. I don't want to do
Never mind. Yes.
I love that, Matt, because I think when we say goals of care conversation, there should always be an S. Like it always needs to be goal of conversations, because holy smokes, like it takes me, how many conversations does it take me to decide where I'm going to dinner? Like, this is important. This is not dinner. This is important. So to see someone, to be in a building where you can see someone and the person can, you can have a little conversation and then time away, and then have a little conversation and then time away. That is a beautiful opportunity to allow the resident the time and space to really consider, to really think, to consult. Who do they need to talk to? Maybe nobody. Maybe the kids, the pastor, the neighbor, there could be lots of people involved in that decision.
Right. No, and I think, again, we have such a unique opportunity as service coordinators because we see those residents day in and day out and can have a 5-minute conversation versus a 20-minute conversation, depending upon what the needs of that, what's going on, how that resident is processing. So in that way, I think it's much more approachable from a service coordinator's perspective, because it's not, as you say, it's not the conversation, it's a group of conversations that really can help a resident formulate what it is they really want.
And especially if you're overcoming misconceptions.
Yes.
So if a resident is of a minority group that has historically been mistreated by the medical system, you can't just say like, oh no, it's fine. They're good. It's not like that.
Yeah.
Right.
oh, okay, let me just erase, generations of,
Yeah.
of
Or,
perception.
we will have to have an advanced care planning conversation. This is called a do not resuscitate. Oh, so you're going to tell me that I need to let my mom die? Yeah, I mean, you're absolutely right. Those kinds of perceptions and understandings are part and parcel to the whole conversation.
Yeah, we used to wish that we could call hospice palliative care, but now when you say palliative care, people just think of hospice. Like it didn't really work. Like we can keep changing what we
Right.
call it.
No, I always used to call it the H word,
Yeah, me
you know what I
too.
mean? Because it conjured up such emotions, which brings me to another point that I want to be sure we talk about. And that is, you brought up a really great piece of insight. And that was whether it's palliative care or the subset with under palliative care, which is this hospice program.
Mhm.
You talked about we're more than just a shell. Could you talk for a few minutes about what I think is your expertise and some of the psychosocial challenges you see with patients as they begin processing, what they want or beginning to understand what they think they want, some of the experiences you've had and any insight you might be able to offer?
The question I always try to remember to start with is, tell me what you heard the doctor say. So I work on a team with physicians and nurse practitioners who I know what they charted that they said, and it's reflective.
Mm-hmm.
But I always start with, tell me what you heard, because that's a really intense, often a very intense conversation. So then again, be quiet, Stephanie, be quiet and listen. And then I measure what I know that the provider said with what the patient or family heard and understood. So that tells me a lot about their psychosocial perception. Like that tells me about, when we talk, if we tease that out, so psychological, are there indicators that this has thrown them for a loop? It might not. They might have been really sick for a really long time and are relieved that someone finally has acknowledged what they already knew to be true.
Yeah.
But, is there grief about their condition, grief about their prognosis, or, how old are they? We have patients that are 100 plus, and they are the only ones left. So many patients say, I'm the only one left. They might have like 27 great grandchildren, but they have no cohort. They have no peers. So, I try to look at grief for self or others that they've lost. They're allowed to be sad. I don't believe in treating sadness. I believe in treating depression. But if someone is sad, that's appropriate. I have had many, many patients and caregivers over the years apologize to me for crying. And when they do it, they're like furiously wiping. And I say, your sadness is 100% appropriate, and you don't need to apologize to me. Moreover, you're not going to hurt me because I'm not related to you. So you can be sad, and I can take it. If patients or families have anxiety, burnout, there's just a lot. I have heard a lot about, getting old, and it's not all it's cracked up to be sometimes. So, but what, how are they reacting, and what intervention might be helpful? I recommend a lot of counseling. I have resources that if someone does have depression or complicated grief, anxiety, I don't believe that there's a pill for I don't matter. And that's what a lot of our very ill older adults are feeling. Like, I'm no longer able to do the things that made me feel like me, that made me feel like I'm contributing. And so that grief and loss, and can be depression, there's no pill for that. So I recommend talk therapy a lot. Not everybody follows me, does what I recommend, but.
Well, no, but I do think, and frankly, the way you described, complicated grief, residents feeling like they don't really matter anymore, you basically summarized beautifully how many residents feel who live in our apartment buildings, who are, interacting with service coordinators all day long. Are you sure you haven't been a service coordinator before? Because that's absolutely, Dan, am I right? Is this not service coordinators?
No, the whole time I'm thinking, oh my gosh, we got to get counselors into our building.
Right, and so many of our buildings, and unfortunately, I think you're bringing up a really good point. Sadness is not treated with a pill. Depression might be appropriate with a pill, but sometimes our healthcare system, a pill is just easier and much more accepted, and frankly, less effort than someone who has to actually, if I can use your word, listen to me and help me process through those things. Whereas a prescription, it's a breeze. Just take it and be quiet, right?
Yeah, and we use lots of prescription. I'm not against psychotropic medication.
Sure. I'm on several myself.
We'll edit that out.
I was waiting for Matt.
You're familiar with Haldol, aren't you?
Vitamin H.
Well, yeah, before we wrap this up, for service coordinators, so their physician's doesn't have a palliative care program. So does that mean they have to go out and find one in their area, a program, and then switch their primary care physician? Is that what it takes? And then my second part of that is, so palliative care doesn't stop if somebody goes on to hospice? So those are my two questions there. The best way for service coordinators to find palliative care in their area, and then also, does it stop?
The best way for service coordinators to find palliative care in their area is to know who the primary care physician is, and have an idea of the major players in the area. So, in Columbus, we have 3 big hospital systems and a really large physician-owned primary care practice that, all have palliative care programs of some sort. So yeah, it would be great to find that out. Now, if you have a resident who specifically has a certain kind of insurance, then you can help that resident call the insurance to find out, do they have a special niche? Like, do they have a subset plan? And then give, the service coordinator can give the language to the resident, like, hey, when do you see your PCP next? And help them, make notes. I'm experiencing these things, and I understand that palliative medicine might be an option for me, doc. What do you think? So
yeah, it just seems like to have palliative care in place, and then when that hospice discussion comes, it's like, oh, well, we'll just ask Stephanie, she'll help us with that conversation. And that conversation's easy, instead of boom, all of a sudden you're hitting up against a hospice conversation that nobody is ready to have or wants to have. So I think
service coordinators don't need to know all the ins and outs of like what's covered in the hospice Medicare benefit, but I think they should all have some experts on deck. That they can call, or that they can link with the patient and or family. You don't need to know all the things. You just, but it's important to know who knows all the things.
Yeah. Right. Right.
So it's like that with mental health. Like, you know somebody that you call when you need a counselor, you know someone that you call when you need to know more about hospice. I think it could just be part of their list of resources that I know they already use all the time. And then your question about, does palliative care stop when hospice begins? Palliative care, hospice is palliative care. So depending on the program, you likely switch teams. You might not see the same people. You might, depending on the program, because some palliative hospice teams, you could transition from one program into the next, but you will still have palliative care.
Mm-hmm. Right.
Because even though not all palliative care is hospice, all hospice is palliative care, but you might have different team members.
Gotcha. Matt, before we wrap up, do you have any questions for Stephanie? Are there any other questions?
No, I was just going to say, I want to be sure that we've covered everything that you really think is most important, Stephanie. I mean, which I think this has been remarkable. Do you have any, I'll call them last words of wisdom to a service coordinator regarding having these types of conversations? Note I said conversations, I didn't say conversation. But besides that, any other words of wisdom or insight you might be able to offer?
I think for service coordinators to be willing to dip their little toe into this conversation would be a huge gift to the residents they serve. Mm-hmm. And I think if they start small, like most people are not super comfortable having these conversations. When I tell people what I do for a living, they back away from me. So, like, you choose to do what? But for the service coordinators, even if they just say, tell me about that hospitalization, how did you feel afterwards? Has anybody asked you what you want? The next time this happens, has anyone talked to you about, do you want to go that emergency room or hospital route again? So it's not about the service coordinators knowing all the things. It's being willing to say, oh my gosh, I hear you that you want to go out of here feet first. And I go back to that because I've heard that like a million times in my career. I heard you that you want to go out of here feet first. How do you think I can help you make that goal a reality? And then
that's great.
Because you're going to need help. We're going to need some support if that's your goal. We're going to have to figure this out. It's just not going to happen.
Right. We'll have to put a plan in place.
Yeah.
Yeah. No, absolutely. No. I think that's great. And again, I loved your descriptive word, gift. It's a gift to those residents, because I will add this. It's not uncommon for many of the residents who live in subsidized housing to have not been asked most of their lives what it is they want, and assumptions made regarding what they should do.
Right.
And so for someone to respect them enough to say, tell me what it is you would like to see happen, I think would be huge. And I'll use your word, and would be an absolute gift. So I think that's a great piece of advice. I think we could even end on. What do you think, Dan?
I think it's great. Thank you so much, Stephanie, for
Stephanie,
joining us. I hope you enjoyed your first podcast experience. You were great. And I know the service coordinators are going to get a lot out of this. You gave a lot of great advice and insight. So I can't wait to hear back from them and see what they think. So thank you so much for coming on, Stephanie.
Thank you, Stephanie.
Okay.
All right. Thanks, Matt.
All right. Talk to you later.
All right. We'll see you guys. Thanks, Stephanie.
Thank you. Bye.